me introduce Dr. BobWaugh. Dr. Waugh has never hesitated to embrace new technologies and protocols if they improve the quality of patient care and oral health. He first identified diode laser technology as a tool for orthodontists in 2004 and has taught extensively on its application in orthodontic practice. Dr. Waugh graduated from the Medical College of Georgia School of Dentistry with both a DMD and a MS in oral biology, and from Baylor College of Dentistry, earning a certification of specialization in orthodontics. Dr. Waugh has practiced in Athens since 1989 and enjoys teaching as an associate professor in orthodontics at Augusta University's orthodontic program. His education company, IntelliDent Solutions, has provided laser certifications for orthodontists for over 15 years. Dr. Waugh, we're so excited to have you with us, and this is my time to hand it over to you. So take it away, sir.
Fantastic. Thank you, Joe, and a nice introduction. Welcome, everybody. And I know, I hate that I can't see you because I know probably there's some familiar faces and some friends and maybe some folks that I've trained through the years. It's really a nice reception that you would attend tonight. And I'm super excited to be here. I just want to thank Joe, who's done a great job getting this organized. And Michael Casilla is also especially to be thanked for getting me back involved with teaching more and more laser. And then my team, of course, and Dr. Rick Waters has helped me with preparing this presentation. Without further ado, though, I just wanted to hope that y'all are in a warm environment. Punxsutawney Phil, this is, of course, Groundhog Day. I know you've heard. He saw his shadow, and there'll be 6 more weeks of winter as if you needed more cold weather. But we're here tonight to talk about enhancing orthodontics. And I just love orthodontics, and I feel like it's a super privilege to be able to do what we do. And I hope that I can show you a few things tonight and some of the thoughts I have about the use of the diode, which I use every day in my practice. So just a little bit about tonight's program. The laser basics have to be covered. I think we'll do that quickly and confidently with because we've got a lot of experienced users probably watching. So if there's some new users, we're gonna go through some of the basics just to make sure it's a safe process that you go through to learn. Then steps in orthodontic treatment. I think it's kind of handy to know like when you do what procedures and when you typically would do things like that and sort of give it perspective. Then we're gonna try to hit the videos. 7 commonly provided diode laser procedures. And so these are narrative videos that we'll go through, and I think it'll add a lot of insight. This is something that I think will be the time well spent, followed by then looking at the contemporary diode laser. And just to preface tonight's talk, we're talking about a 940 nanometer wavelength laser. And so all the characteristics of the lasers that we've used here in my office for years. I've been most familiar with 940. I've used the 810s, but most recently the 940s. And so please take that into consideration. We'll be showing only the cases treated with 940. And then finally, we'll sort of look at some of the cases we've done with the Epic 10, and then some interesting orthodontic cases to wrap up. Please do ask questions. And if, by the way, if I've taught you at some point, throw that in the chat for me. That'd be interesting for me to see later if you have. If you say hello, I appreciate it. I'll try to get in touch with you. It kind of goes without saying, and if we're doing laser basis, we got to talk about education. It was original article here showing the guidelines for how the standard proficiency courses are being taught and levels. This has been done since 1992. It was in San Francisco, but then approved across the world. And so you've got to be involved with taking these proficiency courses if you're going to use the laser in your clinical practice. And so that being said, these are organized really nicely by BioLace, and they've got some stuff on their site that really will help you. This course, of course, will be archived there as well. Continuing education, though, for me is a forever thing, and I know it is for most of you there. So we're always learning, and this is an opportunity. Even as I went through the cases to prepare for this, I'm learning. So it's just great that we're all in this to learn together. Oh, That one sign down in the lower right-hand corner is just to remind me that, you know, it can be dangerous. You want to make sure you do this for all the right reasons, but we have to post these signs that say danger, you know, because it is a laser being operated in this area. We want safety equipment, and you have to be familiar with all of that. And we're going to touch on some of that next. Laser basics, tips and sizes. It's interesting, BobWaugh has the 200, the 300, and the 400 micron tips. Of course, these diameters have different applications. I think in orthodontics, you'll be safe to use the 300s and the 400s. These are the ones that we typically use. The blue one, of course, is something we use for fine procedures at 300 microns or 0.3 millimeter tip. We use that for aesthetic contouring and some of the anterior procedures. The 400 micron for some thicker tissue, some fibrous tissue like palatal tissue or any kind of, let's see, indurated tissue, operculum, retromolar pad, that type of thing. Be great to choose a 400 for. You'll see both in some of the presentations tonight, the videos. By the way, when we always put, those are some interesting curves they've got on those tips from this photo, but I just use a mirror handle, and that way I don't kink or crimp the fiber optic cable, which is a quartz crystal cable. And so you want to make sure that you don't crack it. Of course, the aiming beam can confirm that you've not broken the tip inside that cannula, but that's a nice way to just contour it. So you have a contour angle that we're used to in dentistry. Another thing of basics would be initiation of the laser tip. And of course, we're using the cork mostly. Don't forget your safety glasses when you get started to initiate your setting up. I don't let anybody else turn the laser on. I just usually walk up, cut it on, initiate my own tip, uncover the foot pedal, and go. So I always leave it where I know it's a safe environment for patients, because in an orthodontic bay, you know, you put it at the end of the room if you're going to do that. Everybody's got to wear glasses, safety glasses in the near vicinity. I'm going to play a short video that sort of outlines how to initiate the tip.
This will be a short video showing you the initiation of the tips with the laser on the cork. This is the 940, the Easy Lace 940, and I've frozen this frame so that you could take a look at the very crisp red donut aiming beam on an uninitiated tip. Now with that being uninitiated, we're trying to, with the initiation process, add pigment to the end of the fiber so that it occludes this view of the aiming beam. And we'll go ahead and play now the short video showing that we placed it in contact with the cork. In this case, step on the foot pedal, it burns down, it adds pigment to the tip.
So I'm going to freeze the video real quick. I think it's just going through a slow motion thing, but what we're going to do is probably initiate it to that 1 watt or less. It's easy to just put it in contact with the cork, let it dive down, then come off the foot pedal before you withdraw it. Because if the heat is being absorbed by the cork, and if you bring that back out into the air, it'll light up and it'll burn it right off. And then you're not initiated and you see the aiming beam again. So if you break through and you've got the pigment or this carbonization, the carbon at the tip, you will not see the aiming beam, as in this case right there. So I'm going to back up. I think I'm going to have to move forward, but the aiming beam, now that's one of the most common things that people do in an error in initiating, is that they think they're initiated, then they burn it off before they go to the tissue. So if you have an initiated tip, travel to the patient before you step on the foot pedal, put it in contact with the tissue, and it'll absorb the heat as you get started. If you think you're just not cutting well, you're probably not initiated. Another good laser basic thing would be what topicals we use. We use a compounded topical called Tricaine PE, or PE for phenylephrine. That is a combination of these ingredients, a 10% lidocaine, 10% prolicaine, 4% tetracaine, as hence the tricaine, and then 2% phenylephrine. And we used to call this Profound PE. And we used to get this on a regular basis from these companies. And then I think there's been an interruption in one of these companies and became unavailable at some point. So we're just compounding this locally at a pharmacy. with these ingredients. Just order it with a little flavor, order it in thick, and I think it'll work well for you. So when is a laser used in orthodontics? Well, break it down into pre-treatment, during treatment, and post-treatment. You know, a lot of the pre-treatment things we just don't charge for. What's included with the treatment. Things during the course of treatment, depending on their use, their applications, you know, we may or may not charge. If it's something that we're doing to help ourselves, usually we're not charging. If it's something at the end of treatment, a lot of times these are procedures that would have to been done by a periodontist or someone else, and or surgeon maybe. But we'll try to help patients where we can. In some cases, we have to charge for those things. But it's really a value-added thing to provide laser for your patients. Encourage you to get experience, you know, and then charge accordingly for things you like to use. Well, pre-treatment, we do a lot of gingivectomies. There's a lot of cases I look at, and in the exam room, and I say, you know, I just don't seem to have the crown height to be able to get the brackets on correctly. So I'll say, you know, we're going to recontour this, 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 and this. And we set up to do that prior to placing the brackets. Operculectomy, I just don't like to go for very long if we don't have an opposing tooth and we have a retromolar pad covering half a tooth and get some decay sometimes. So I'd like to do those right out of the gate. But then during treatment, you might have some hygiene problems. That's where the gingivectomies come in. Ulcers develop sometimes, fibromas. You can take care of those during treatment. Post-treatment, that's where the frenectomies are done. That's where we get the aesthetic recontouring and the hypertrophy under control. A lot of times is at the end as we finish the case. So it's time for some video. Let's look at some procedures and some teeth. We got 7 common procedures. We broke these down, and I'm going to be talking about these following 7. I won't read this list, but we'll go through them one by one, beginning with bracket placement. You know, everybody, the bane of orthodontics is these second bicuspids. We're all anxious to get the braces on and get it going. And sometimes even when the teeth haven't fully erupted. And so sometimes passive eruption, altered passive eruption, will bring the tissue with it. And to get the bracket on accurately, we've got to do a little quick procedure. So I'm looking forward to showing you this next video, and I'll let it narrate itself.
Next procedure is the gingival recontouring for bracket placement. First step is to assess gingival depth. So you get your probe to the depth of sulcus along the facial area where you're planning to reduce the tissue. Make a mental note of the depth, transfer it over the facial surface. You can actually add a little labial pressure to make a temporary indentation in the tissue. And you plan your procedure. It looks like we have ample tissue, so apply the topical anesthetic. 3 minutes later, we can suction and rinse that anesthetic. And again, peak anesthetic effect is going to be at approximately 6 minutes. So it's time to get the doctor. We assess the level of anesthesia simply by using a explorer or scaler in this case. And we're testing to see if the patient is pain-free. The typical depth of penetration would be 2.5 millimeters. So it's easy to probe here again and evaluate to make sure they are numb all the way through to the depth of sulcus. As for the procedure, this is with an initiated tip. You'll see we're using a 400 micron tip, and we're starting not at the tip of the papilla, but just lateral to that. You're going to make a crescent-shaped incision or at the surface of the tissue, and then retrace that incision, moving at a speed that we're comfortable at, that produces very little charring or carbonization of the tissue, and working back and forth with each pass in a deeper level, and allowing the laser to do the work and ablate the tissue. Soon enough, you'll find that you feel the contour of the tissue, and literally in one fell swoop, the piece can be excised, and exposing then the area where you plan to bracket. This video, being in real time, gives you a real good idea of the extent to which you would operate. It's only just a few minutes. Here I've got a little tissue tag that I'm trying to take back just to clean up the procedure. It could easily be scaled at this point, more than likely. And you'll notice that we've got some tissue debris on the facial surface. If you weren't bracketing, you could clean this up with some peroxide or vitamin E. In our case, we're going to move on to cleaning this area with the self-etching primer. The self-etching primer is applied using a microbrush, and we scrub the enamel to create the etch and to remove the debris. And it can all be applied in one 5-10 second scrub, and then you're in position to then dry or thin that sealant and apply the bracket. Get a nice clean surface to bond to. We're going to blow that thin as the assistant's also getting the bracket pasted and ready for application to the tooth. So with only just 3 minutes or so expired at this point, in real time we're able to see that there's a great application for the use of the laser to expose and then bracket in real time. Finally, we'll cure the bracket to complete the procedure.
Awesome. We use a lot of offset brackets. So a lot of times we're pushing the brackets under the gum. You know, for better bond strength, though, a quick laser procedure is the way to go. Thought the procedure there was pretty neat and clean. We now use a warm air dryer. That's also with the LPOP, the self-etching primers. All right. Well, I think we'll let's see, I'm going backwards. Let's try it again.
Next.
All right, let's move on to aesthetic contouring, recontouring. I think this will be interesting for you. This is one of my favorite procedures. It's usually really exciting for the patient. This will be usually after debonding, but we'll take a look at what we've got in this video. I don't have audio on this video, so we're going to actually try to move in, and I'll try to stop at a good point where we can kind of describe what we've done so far. Let's pause it right here. So what's happened so far is we've really done a full assessment by probing and seeing where we're going to be. Like, for instance, this central incisor, you know, we know the proportions of natural teeth. We got to pull an x-ray. We look at it in the x-ray and we see that they have natural proportion, meaning this incisor is 80% as wide as it is tall to the CEJ. And so we know we have room. We would probe and see how much we have. So if this was 8 millimeters wide, for instance, we could go as far as 10 millimeters high on this tooth and be within proportion. A nice way to go about it is to, of course, probe first and make sure you're at the base of the sulcus, not beyond. And all of the keratinized tissue is adequate, meaning 2 millimeters or more should be remaining after you finish of keratinized and attached tissue. So you would want to make sure you could probe the sulcus, have at least 2 millimeters of keratinized and attached tissue, and then you could then do that technique where you just mark the tissue by pulling your probe out, put that little dent or that intended height at the zenith of the cut. It's not right on the midfacial, as you know, probably a little bit of distal facial on the central. But now I'm going to go back to hopefully playing the video, and you're going to see that I'm trying to get this all in one pass. It's the nicest way to go if you can neatly and cleanly take that crescent incision and then peel back that tissue. And then you don't, as it's cutting, as you understand, you know, the laser light is coming down the fiber and is focusing on the initiation that you've got at the tip. Of course, the laser is an end cutting instrument and not a side cutting instrument. So unlike your handpiece, a lot of us make the mistake of thinking we could cut with the side of this laser. It's the heat is at the tip. And so this is just a couple of different shots showing they were going for it all at one time. If you dab at it, or if you have to go back in to get a new bite, you got to find a new area of tissue that has water in it, because the laser has an affinity. The laser light has an affinity for pigment and for water. So if you've dehydrated the tissue with a previous cut, you're likely to carbonize or burn the tissue the second time around. That's why I like to kind of just go for it, mark and measure and go for it. And then you can see we got a little carbonization, but it's all about speed, and it's all about intensity and wattage. And so you've got to find your happy medium there. But what a great procedure, especially at the D-band. I'm actually going to stop the video there. and show you a before and after. I remember this gal. This was actually one of the first procedures I ever did with a Easy Lace 940, and just shows you patient came in for the D-band, and we brought her in on a Saturday because we just received the laser, wanted to take plenty of time with it. And this is she went to the prom that night, and how fantastic is that? That she could go from this result and be able to go up to the mirror and see that change in the smile. Fantastic. Here's a little closer look. I look back, that wasn't bad for a first run. So we'll love that. We'll take that any day of the week. A procedure like that could take as much as 20, 30 minutes, so that give you an idea of the time we spent to do those cases, to measure and then go in and do it. Just a couple of tips there. Probing depth is big. Avoid the biologic width. We'll talk about that, but you're trying not to heat up the bone, the crustal bone. And so you got to use your probe, and then you've got to move your probe out. So if you have a 2mm pocket, just move the probe out 2mm on the facial side and just see where it lands. Direct the laser apico-incisally. So you're coming at a bevel. You're trying to create a coronal bevel, not leave a shelf of thick tissue that catches plaque and all of that. Think about the end of the cut being where the tooth is, and you start a little higher than you need to be so you end up at the right spot. Incrementally, you're going to deepen it. Usually 1/2 millimeter per slice is a good guess. I don't think there's any way of knowing, but you're looking to just trace and retrace those and then clean up the edges afterwards. The golden rule for me is this: only excise tissue where super bony pockets exist, where attached and keratinized, it's the and being the key word, attached and keratinized gingiva is adequate, meaning 2mm or more, and evaluate for and not passing the CEJ. So with your probe or your Explorer, just be sure you're not cutting or exposing the root. You want to see if you can feel the CEJ, and of course study your x-rays prior to treatment. So we'll move on though. Another common procedure would be the labial frenectomy. Labial frenectomy is a really cool thing you could do. One of your earlier procedures would be nice to do that. Let's watch and see what we can learn.
Here's a great look at an easy frenectomy. This would be a nice procedure to do as one of your first procedures. Notice that the assistant is blowing air and suctioning while I retract the lip. With topical anesthetic applied, I can easily start to reduce this epithelium cover over the tent-like connective tissue fibrils that run from the lip to the base of the central papilla. Now, you don't start the incision at the tip of the papilla, but rather where the fibers insert into the tissue over the alveolar ridge. Here we're dissecting out and trying to get a good look at the connective tissue fibrils, which are white, by the way, and may require a little more time in that area to deliver the heat necessary to cleave those fibrils. This is just a good look with the aiming beam off at the tissue. We're going to continue to develop this incision laterally and expose, you're not trying to expose the periosteum, but rather just expose those fibrils and cleave those for a complete cut.
Now we usually ask the patient to just blow a little air under their
Here's
lip
a great
after the procedure for the rest of the day, the next day, just to keep it from healing back on itself. That's made the point, but not clearly. But the fibrils are white, and there's no pigment, of course, and it takes a higher wattage to cut them, or you have to stay in the area longer to cut them. But you're really just trying to detach the lip, which every time they smile or swallow or laugh or eat, whatever, it's tugging, and it's running through the alveolar ridge, on the lingual side, and inserts there, and sometimes divides the teeth. So we take on the idea that we close the space first, then do the frenectomy at the end of treatment. I know there's different training for different people there. Another great procedure is this hypertrophy. Even in cases where patients, have pretty healthy tissues, some of these papilla flare up from time to time. It's just because they can't floss as easy with braces. So we'll take a look at some of these cases. This slide shows spontaneous resolution. In other words, no laser procedure was performed on this patient. So this is just 9 weeks later that you can see the the swelling has gone down, and they've avoided a whole procedure. So a lot of times, even though they're debanding, we'll schedule them out to see if it's super fibrous. So we'll come back and do it. If it resolves on its own, then no need for laser. Case like this, though, you know, you take the braces off, and then 6 weeks later, it's still looking like this. It's more fibrous, and it's not likely to go away. And so this is one I would indicate a laser is needed, and we just recontour in this case probably at least the upper 6, if not 8 front teeth. This shows we'll flash back in time here. This is biologic width. This is the 2 millimeter zone where both epithelial and connective tissue attaches. And so at the base of the sulcus, we're trying to preserve this. So if you were going in to reduce hypertrophic tissue, you wouldn't be beveling in. You'd be trying to lop off the top of this papilla, the swollen part, and you'd be coming from the root towards the crown and trying to cleave off the top of that and not invade biologic width. And consequently, you wouldn't have any heat transferred to the bone, and you wouldn't lose bone over the procedure. So a pretty important point. Case like this, obviously we debanded and the tissue looks pretty rough. But all we did here in this case is just cleave off the top of the papilla. I'm going to try to take a look at that procedure here. And I'm going to shoot down to a point where we can really see one of the better procedures. And
average height papilla. Here we cleave through the very top of the papilla, and you can see that as that piece is removed, you get the more typical display of the teeth. This step back view shows you the orientation of the assistant who is cooling the tissue with air and is suctioning off any plume as I operate, working from the base of the papilla, aiming at the contact point in a rhythmic motion. We work our way through the tissue, and it's a very effective way to remove the tissue without creating any carbonization.
Awesome. The next, the fibroma removal. It happens occasionally. Let's see what irritational thing from the braces sometimes, but rather than send the patient out, it's nice to be able to do it yourself.
The fibroma removal is one of the more random procedures we'll do on occasion. It's nice to take care of your own problems. If this fibrous enlargement is due to irritation from the braces, this gives us an out as to how we can best handle the patient's care without creating any new charges for the patient outside the practice. So it's very simple to use a tissue forceps in this case to delineate the attachment and then working our way around. We're using the Easy Lace 940. You can see we're just working in short strokes to detach the tissue at the level of the mucosa, and it becomes a pretty straightforward procedure to expose this stalk and then have access to remove the attachment. By working our way across, we just repeat the same line and preserving then any part of the fibroma that you'd like to keep free from the heat, the thermal damage, in case you want to biopsy this, just to be safe and just to be sure. Now this will be one of the quicker things in terms of healing for the patient, and it's immediate relief of this, and then monitor the patient to see that you remove the irritation that doesn't reform. That's a good look at the removal and the minimal damage to the tissue. This will heal up nicely.
The sixth one is for aphthous ulcers. Now, mentioned this is the garden variety aphthous ulcer is something you can treat. You'd be doing that a lot throughout the day, so we're not looking necessarily to slow our days down with these things, but you can really make a friend if you've got a patient that has recurring aphthous ulcers. You can treat these. We'll talk a little bit more about this, but let's keep through to the video. But pain therapy is something that this the laser, the 940 wavelength, does a good job of. It's called photobiomodulation, or LLT, which is low-level laser therapy. And this one is used, of course, this is done for extraoral, and it can be used for TMJ or tendonitis or any kind of deep tissue laser therapy. So what you're trying to do is allow the laser energy to come through and have a deeper penetration. You do that by not initiating and not putting it in contact with the tissue. We'll take a look at this ulcer treatment in the mouth.
The next video is on the aptus ulcer. This is a great example of using uninitiated tip defocused for warming tissue. Now I'll peel my glove back and just try this on my hand. Notice I'm going to keep the laser moving. And this is the patient's ulcer. It's a pretty bad ulcer for this patient. What we're doing is we've set the laser to 3 watts continuous wave, and we're keeping the uninitiated tip, allowing the laser energy to deeper penetration into the tissue, and we're hovering above the lesion and working around the edges of the lesion where this is swollen. This is how we are creating better vascularization, and it takes the pressure off of the tissue, allowing the tissue to absorb some of the swollen areas on the periphery of the lesion. This is a smaller lesion right at the edge of the vermilion border, and you want to keep this moving, trying to deliver about 50-60 degrees low-level laser or cold laser therapy for the patient. The patient is not anesthetized, so they can give you feedback regarding the warmth of the tissue.
So, key points there were defocused, not in contact, not initiated, and you work from the way out and work in, keep moving, 3 watts continuous wave. And so we do this on occasion. It's one of those things that you'd be covered up if you had to do this all day for patients that come in with ulcers and irritations like that. But we help patients from time to time if they got something like the one you just saw. Finally, let's wrap up the videos with the operculectomy. This might come in handy if you're fitting a steel crown or trying to pick up impressions or something like that to fit crowns. I'm not sure anybody's doing that with all the scanning these days, but the operculectomy, again, could be retromolar pads, could be just you're trying to clear something so the patient can clean their posterior teeth. Let's look at a quick video on that.
This is going to be a nice view of a operculectomy. The second molar has erupted, and there's a thick, fibrous area of tissue that's got to be excised to make this tooth cleansable. I'm sure you've all seen cases where either a tooth shows some early decay, possibly even requiring root canals. And so it's great to get on these as soon as you can upon eruption. This is a good view starting at the distal lingual, operating at an angle pointed away from the tongue. We've already got our local anesthetic in place. As the tissue shows good thickness, it's probably 4 millimeters thick or so. Could not get a good topical anesthetic effect from the TAC 20, so in this case we just infiltrate with lidocaine. Now you'll notice that I'm circumscribing the what I can consider the visually, I guess, where the posterior aspect of the tooth is, and I'm looking to cut at least to the distal margin and try to get this all in one pass. It's probably a lot easier to get this in one piece than to go back to have to get a second cut. So it's great that use the laser as a way to sort of palpate as you get close to the tooth, and you can feel the contour of the tooth as you continue to excise that tissue. Operating away from the tongue, ending the cut at the corner of the distal incisal line angle. Because of the lack of keratinized tissue in that area, it's nice to be able to wind up your incision at that point, preserving all the keratinized tissue that you can. You can see we got that off in one piece, a nice clean exposure, and this tooth ready to seal or bracket.
A lot of times we'll see this in our practice in second molars or mesioangular impactions. We'll make something called a Halterman appliance, which is a modified lingual arch with a distal extension. Be sure to scan upper and lower in this case so you can sneak it in there, but try to expose the second molar and try to get as far mesial as you can with your eyelet or bracket. We'll put it right on the occlusal table, and then we try to tip it back so there's no rotational effect. And this is 2-3 visits for us. We do this a good bit Halterman appliance is a great find to learn that from another doctor in Augusta. Let's take a quick look. I'm looking at the time. I know we'll have to move pretty quick. Looking at contemporary diode laser, the BioLace Epic X or Epic 10, Roman numeral 10, I guess, 22 soft tissue indications. By the way, it has the home screen has the 3 areas: the soft tissue procedures, the whitening procedures, and the pain therapy. We pretty much are clicking soft tissue procedures, and they're listed there. They are preset, and it's really nice to go through and just select it and not worry that, of course, we're starting with the idea that the lower level is suggested, and then you work up based on your proficiency and what type of anesthesia you have. Laser procedures like curettage, troughing, gingivectomy, frenectomy, all of those are preloaded in. You can even do some custom ones. So if you wanted to put in something for the aphthous ulcers, you could do that, or hepatic lesions. There's also a nice thing called comfort pulse. You can select how you want the interval of the energy delivered, whether it's continuous wave or whether you want to do a 50-50 pulse, meaning that's on and off for the same amount of time. Or it can be as cool as doing a 20% duty cycle, which is nicknamed the comfort pulse, or CPO, comfort pulse technology. And that's it's on, I guess, 0.1 milliseconds and off for 4. And then so it's 20% of the time. And so it's at a high hertz. So it's cutting across, but it's only firing every so often. And you're less likely to burn the tissue, which has everything to do with the patient's comfort and post-op pain. 10 watts of power is a lot of power, but you've got to have that so you can cut it 20%. So 20% of the 10, is 2 watts. And so you've got 2 watts. If you can do most laser procedures done between 1 and 2 watts. Now you can do pretty much every procedure on the list at comfort pulse with a 10-watt laser. Now let's look at some more cases. Every case here I've done, in the last 6 months with our Epic X. I'm finding that I'm using a good bit on impacted canines. I threw this slide in just to let you know a lot of our canines have no choice. The surgeons have to expose them and put their brackets on the lingual. And so I know as we bring teeth in, we sometimes have to move the brackets to the facial. This is where redundant tissue usually exists, and we're able to reposition. And that's just a slide to remind me to mention that. Here's a case that I thought was interesting with the anterior open bite case, tongue thrust case. Having trouble closing this case down. So what I did was I removed the 4 incisor brackets. We did a laser gingivectomy, and I repositioned these up, and then you can kind of see we're working to close the bite through superior positioning brackets similar to smile arc. It's kind of an interesting case. I was using because it was so thick and fibrous, I ended up using a 400 micron tip, and this looks a little rough on the surface, but it was tough tissue, and I wanted to bevel it. So this is for a patient with vertical maxillary excess and a ponic. So we just there's the way it went. We saw her here up the upper left. You can see the VME on the facial photo. The ponic came right off the flipper. So she has a ridge runner kind of flipper, and we just parked it right there. But you can see the result because she was unable to clean around it. We got all this hypertrophic tissue and wanted to clean it up. And then we debanded, and we were ready to deband upper. Wanted to do a quick laser procedure and refit that ponic on the retainer. And so here's sort of a before, during, and after look at the case. And obviously, I think she still has some room to go on the lower still, but we're happy that she is happy with a much nicer smile. Also, another procedure we do a fair amount of is we just uncover these so we can bracket mesioangular teeth. You want to get a bracket down lower, the lower right 7 in this case. You got a little operculum to remove. Just neaten and clean it up, get a mini bracket on. I love this little tissue forceps. Has teeth on the end of it, and I can just lift the flap up and cut from both sides. The thing about topical anesthetic is it only really profoundly numbs about 2 millimeters. And so, but you can work it from the underside and the overside and sometimes get it done without injection. So like we did in this case. Erupting canine, this is This is a garden variety canine that you can see come in. It brings a lot of tissue with it. We want to get a bracket on it. I usually use a rule of thumb that we don't want to cut any higher than maybe the margin on the central incisor. I've had also, you want to maintain the 2 millimeters of keratinized tissue, as we did in this case. This is the day the laser procedure was performed, neat and clean, no bleeding and no swelling, of course, with any diode laser. And the bracket gets positioned ideally, and we can drop them in with elastics. And so that's a pretty routine procedure for us. What about this labial papilla that's sort of hypertrophically overgrew, and you take the braces off? Obviously, this patient had hygiene issues. We got some decalcification, but you know, you could send them out the door with this, and it'll be 2-3 weeks. That'll look better. But what a nice way to go if you can just do a patient a favor and cleave that off. It looks like a big procedure, but you're just taking the swollen part off, aiming at the contact point, and you just cleave it off. And it's a neat and clean procedure. This is a new case. I'm starting on showing you the x-rays first. Many cases, this is a sector 4 impaction of upper left canine. It's all the way behind that lateral root. In fact, it occupies the space the lateral would have occupied, and it's pushed that lateral almost through the labial bone. In a case like this, we're careful about bracketing those cases and not wanting to perforate the bone. But you can see in the series, working from the upper left side, you know, under that tissue is that canine. If we are sending the patient to the surgeon and they're going right away because this is more urgent, that we don't get resorption or any perforation, we put a button on, you know, just say tie off on the button, because we don't want the surgeon to run it up over the ridge, take out the primary canine, and then run it up on the alveolar ridge. In this case, we maintain the primary canine. We've got it exposed. We're working off a modified TPA with a mesial extension and thread. And then sometimes, though, the tissue keeps ballooning up as the tooth moves, and the tissue comes with it. And then it's nice to use a laser. And once you've gotten it away from the roots of the lateral, you've erupted it some, and you got room to place an eyelet on the facial surface. So this is the day the laser was performed. Now we're able to, you know, move in. I've got a larger rectangular wire, anti wire that we've engaged. Now we can go in and expose it again, do the bracket, cut the hooks on the canine bracket, and then you've got the tooth in on the arch. That's a lot of what we do just to speed things up for our patients. Here's a kind of interesting case with a incisor papilla complication. I know you've seen this with your patients, that you got tissue building up as you change space closed. Sometimes an inflammatory reaction, possibly dealing with the incisor papilla and the neurovascular bundle that exists there. This shows the history on this patient that has, working from the upper left down to the lower right, the upper spacing was consolidated with chain. We had a little flare up of the papilla. We cleaved the redundant tissue, and the deep bite was impinging. And then months later, I think as we continued to close, as she was unable to clean, a lot of this inflammatory reaction came back. Now, this is not something I would expect to do if it was your first laser procedure, because there is a vascular bundle there. But keep in mind that you can carefully cleave this off if you take on the right trajectory with your laser. So you're going to get up back on the palatal aspect and work towards the teeth, working towards the margins of the teeth and the contact points, and you can cleave that tissue off and resolve a huge painful problem for the patient that has an impinging deep bite. So we're winding down, and I wanted to take time to touch on 2 subjects, I guess, to wrap this up. One being smile arc. When I look through the patients I've treated, we used to have a local photographer take photos, and I love this smile. This is probably one of my favorites for smile arc. You can see how our teeth follow the contour of our lower lip. This is what we all aspire to do. Which smile do you like? The one on the left, the one on the right? Obviously, the one on the left has been has really flattened during the course of treatment. The one on the right, the smile arc was preserved and protected. So we're going to talk about this case in terms of smile arc modification, laser access, and rebonding for smile arc. Unfortunately, this is one of my cases that I flattened this well before I even knew about smile arc. Thanks to David Sarver and others, we now know more about it. But pre-treatment, this is how we look. And I let the tissue kind of limit my ability to get the brackets where I wanted them. And you can see that here, the tissue is now encroaching on the brackets. There's a lot of inflammatory tissue. And then we deband. It's not perfect, but we got out with I thought a nice occlusal result. But what about the smile arc? I look back at these pictures and I'm like, wow, they did flatten. What can we do about it? It happened to be this patient stumbled back in with a loose retainer and one minor rotation came back. I looked at that and I said, I'm going to go back in and help fix that. When you took a look at her original occlusal plane and with the first treatment, and then how she finished, you can see how it flattened. Normal occlusal plane 8 to 9 degrees from Frankfurt. It's like 2 degrees to Frankfurt in the right side where we started. These are slides I borrowed from Tom Pitts. It shows smile arc protection is a much more gingival bracket placement. And it increases. Usually if we're measuring, we do traditional bracket placement, we're usually at, we are shorter on the lateral than we are on the canine. So we are working our way up here. It increases. So if you're at 5 millimeters or something of the canine, you're at 5.5 on the lateral and you're at 6 on the central. You're graduating as you go from back to front. You look at the testoma and you can see the change on this patient and the steepening of the occlusal plane and the incisor extrusion. So how did we go about doing this? We had the patient in and we got rid of that redundant tissue. That extra tissue allowed us to put brackets on higher. Here I'm doing the work with a laser. I've worked with Tom Pitts at a course one time and he did our bracket positioning, but this just shows some of the same procedures we've already shown. But look at the positioning on these brackets. And so what you're trying to do is graduate the brackets and extrude these upper incisors, trying to intrude the lower. You're trying to increase the steepness of the plane. And if you take a look at the progress with this patient and look at the outcome, you'll see that that smile arc has greatly improved. We're so happy to be able to be a part of a case like that, that we're able to go back and see. But if you're looking at your final cases, you're looking at like you flatten those smile arcs, you're doing traditional bracket placement. This is a great opportunity to learn how to get some real estate with your laser so you can come up and get those brackets on a little bit higher and improve that smile arc. Make a huge difference for the patient. The final case I'll show here is one I just call D-band celebration, because at the D-band, we should be celebrating. We should all be excited about this. And you never know when you have a patient like this, when they come through the door initially, what's going to happen. You know, like, is this going to be a good cooperator? I think if you look at her profile, she's got mentalis strain. She's probably a mouth breather. You go and you put brackets in her case and you're mouth breathing and look what happens. So it's not always what you expect. You think a little cheerleader like this is going to be a great cooperator and is going to follow all the rules and going to brush and clean teeth, and it doesn't always happen. So here we are at a course that we taught in Atlanta at the D-band. We're going to take the braces off. We're going to actually do the laser procedure and clean this case up, and she's going to go to the mirror and see what we finish with. Now this would not be a very wow procedure, you know, look, if she goes up to the mirror and sees this. So we did not let her get up. We kept her in the chair, anticipating that we're going to lop off these papilla and clean all this up. You can see actually the gingival margins at their zenith, you know, really don't need to be contoured. It's these papilla where she wasn't flossing that really need to be cleaned up. So we've got a video, and I know we're short on time, but I'm going to hopefully get it to a point you can kind of see. Start at the base of the papilla. This is the area where the attachment, that the biologic width is not involved. You're aiming at a trajectory at the contact point. And once you see it dive in, you keep going at the same rate. If you're not carbonizing when you first go through there, if you stay at the same rate, you can't see what you're doing, but you're allowing the power of the laser to cut through. And look how neat and clean that is, that we're walking through this without really any carbonization there. Really cleans up pretty well. Obviously, we're getting it. This is interesting because the mom was a photographer. We took pictures at the 0 mark. That picture on the upper left is her at the D-band. And then each day, just to show you how the tissue does improve on a daily basis, we got her back in our own office to do the retainers on day 5. And there's 6 through 11. She's still not flossing, but she's so much better. And I think it's really fun to send them to the mirror when they could have seen what's on that upper right-hand corner of the screen. Let's watch a short video to show her reaction when she does see her smile for the first time from braces being removed. So try it again.
She's playing along.
So she's gonna look in the mirror and smile real big.
Better fix her hair.
Use a little hand mirror
She
too.
wasn't counting on that.
Okay, ready? Go.
Do they look better to you?
Don't they look great?
Let me
Oh
see.
my gosh.
Open. Let me zoom in on. And I want to do some close-up photographs. of
Oh
it, too.
man, I tell you.
Wow.
I wish Mama could have seen that first expression.
Is that
I know. Well, we'll have to send it.
How awesome is that? That's what we're in it for. Changing lives really is why we do what we do. It's moments like that that really make it all worthwhile. Couldn't have gotten there without the laser on that day. And if we're doing this and learning and we're got the patient in the center of our focus, you know, this is the opportunity to really make a difference in someone's life. I know we're run out of time, right on schedule. I think we're about 5 minutes before the hour. I'll stop and want to thank everybody for your attendance and your attention. And I'm more than happy to handle some questions. I'll turn it back over to you, Joe.
Thank you, Dr. Waugh. Man, that video at the end made my night. That was awesome. So thank you for showing that and wrapping up your lecture with that feel good video. All right, so we have just a few questions that I wanted to hit on, and to the audience members, thank you for posting a few questions. Dr. Waugh, you did get a few people on chat
All right.
say hi that you have trained and met in your journey. But just to ask a couple questions here. Question number one, do you always send in fibroma removal for biopsy?
No, I would say that if the fibroma lines up with an obvious irritational problem, you know, you can see a wire or bracket that was irritating it, then it's pretty common to just feel it and know that it's totally fibrous and it's innocuous, so it's benign. So I would say that's a rare. I mention it because I have to, but it's if it's something you don't identify, you know, that's definitely different. Of course, I would refer those things out. When you cut with a laser, you're going to burn the tissue a little bit, and then under a microscope, they're going to see. You've got to have a pretty good margin from that to make sure they can read it. So I'd be sending those out and get those with the scalpel.
Great. Question number two, is it the same procedure for cold sores as for aphthous ulcers?
Yes, and I think this is a good question. You know, I've sort of worked through that, but yes, cold sores are a little different. So you would, but you can. I think the point is that the part that hurts with a cold sore or with an aphthous ulcer is the area that's swollen. You think it's the center of that lesion because it looks the worst, and that's where it is ulcerated and necrotic, but it's on the periphery. That's the tension is there because it's swollen, and so you can literally see that swelling go down on either of those lesions. So now it's important not to be in contact or use a initiated laser on a herpetic lesion, because then the plume of that smoke, if you're not evacuating that properly, and you're in there with your eyes and your mucous membrane and you're breathing that, if you can smell any of that smoke, you know you're not evacuating it properly. So that way, in that situation, you know, you would want to be, of course, defocused, just non-initiated. Make sure you don't make that mistake, because you could get an eye infection or something like that from the virus.
Yeah, and I believe that may have just answered one last question that was posted in the chat about your assistant applying constant air. I believe this was posted during your case videos. That may be evac, but anyways, the question is your assistant applying constant air while you are utilizing the laser?
That's correct. Yes. So we And I'm mostly to redirect the plume of smoke. Like if you didn't have the air going, and you just had the evacuator, she'd have to be right on it or a really strong suction to pull that plume off where you're not smelling it. So we direct it really from away from the nose, away from the operator, directly into the high volume evacuator. And so that is running at full. The air is running the whole time. In fact, I instruct my assistant that you start the air and I begin. And then if I finish, then you stop the air. So we never have the opportunity to breathe it directly.
Great. That's great clarification there. Thank you. Okay, thank you, Dr. Waugh. Those were all the questions that we had.